welcome everybody. Welcome back to the fourth in our series of webinars. Especially delighted tonight that there are 42 people who have registered for the webinar, so that's fantastic to see. Thank you. For those of you I haven't met, my name's Peter Field. I look after TDSA, the Dental Solution clients here in New South Wales and ACT. TDSA is delighted to be working with Respiratory Dental Institute. Joining me tonight from the Respiratory Dental Institute is oral specialist, Associate Professor Michael Stubbs, and sleep physician, Dr. Linda Schachter. Michael and Linda are based in Melbourne. I wanted to say a big thank you to these two. They work extremely hard and put in a lot of time in preparations for the webinars that we're bringing you. So thank you, Michael and Linda. You would have registered tonight for the webinar via the RDI website. If this is an area of dentistry that you are interested in, I'd just encourage everyone to go back, revisit the RDI website, and perhaps have a look at the online courses that are on offer. Tonight's webinar is being recorded, and we will be putting that up on the RDI website and the TDSA website. Could I ask everyone to mute their computers? Send me any questions that you have on chat, and we'll get to those questions at the end of the evening. Linda, can I hand over to you first and perhaps ask you a couple of questions about sleep studies and bruxism? Does a sleep study always pick up bruxism?
Most sleep studies, particularly level 2 sleep studies, don't actually look for bruxism. So if you're going to pick it up in a normal sleep study without a specific submental EMG, then the chances are then the person is bruxing really badly. So if you want to specifically look at it, it is important that you do ask for a submental EMG so that you're looking for bruxism. So it is important to ask for it. The other thing to realise is that bruxing is often intermittent. So even though the person may brux, they may not brux on the night of the sleep study. So if we don't see bruxism on the night of the study, it doesn't mean that they don't brux. So I think there's the two things, is one, making sure that we've got the right leads so we can actually see the area and the submental EMG looking for bruxism, and the second one, just understanding that even if you don't see it, it doesn't actually mean that the person doesn't brux. Right.
Thank you. And I guess that leads to the question, how often would you, when a patient is wired up for bruxism, how often are you seeing it in those patients who have sleep apnea and bruxism? It's a fairly broad question, I know.
I suppose on the patients that are referred for bruxism, and we usually do see something. I mean, the EMG leads are actually fairly sensitive, so it's in the more severe patients that we do see it. So we usually do see something. However, the fact is that, do we always see it? No. Do we always see sleep apnea? And the answer is no as well. So, but they are correlated. So particularly in mild sleep apnea or upper airways resistance syndrome, we may be seeing bruxism, or if we're looking for bruxism, we may be seeing upper airways resistance syndrome or mild sleep apnea, as it has been renamed. So the fact is, we often see them correlated together. What percentage? I'd need to look that up exactly, but it is a common thing to see both together on the night of the sleep study.
Linda, thank you. Michael, I might hand over to you now. Michael, you've spent a lot of time putting your presentation together, so I'm going to share my screen, and hopefully we can start on the presentation.
Thank you, Peter, and welcome everybody. One of the, I think, interesting topics for us as dentists is bruxism, and in particular, treatment of bruxism. And we know that, if we just change the slide.
Sorry, Michael.
That's all right.
Here we go.
We know that the definition of bruxism, as the most recently accepted definition, is really, it means the repetitive jaw muscle activity characterized by clenching or grinding of the teeth and bracing or thrusting of the mandible. And bruxism actually really means gnashing of the teeth. So when you get a patient that says things like, well, I don't grind my teeth, I just clench them, the term bruxism is still applicable. There was perhaps a misnomer that bruxism really just referred to tooth grinding. And it's interesting too to note that bruxism is the third most common form of sleep disorder behind sleep talking and snoring. So we understand that in most people's lifetimes, 80 to 90% of patients will brux, i.e. tooth clench or grind their teeth at night at different times of their lives. And it's not necessarily an abnormal behavior. What makes it interesting from us as dentists is when we look at it and we start to associate it with other conditions that we might see. These conditions may be temporomandibular disorder, patients presenting obviously with facial pain or jaw pain in particular, fractured teeth history, particularly where patients are finding that they are more repetitively breaking or fracturing their teeth or restorations. And so the interest in bruxism has significantly increased, certainly in the last 10 to 15 years. If you care to take a look at literature, particularly in the last 10 years, there's over 1,200 review articles looking at bruxism. So in adults, we estimate that about 8 to 13% of adults sleep brux. And you can see a photograph here on the top left-hand side of this slide, and clearly everybody will be identifying significant tooth wear that you can see. I think the important thing here is to remember that when you're looking at teeth, unless you have the benefit of digital scanning and very detailed history based on the previous study models, the reality is you're looking at a lifetime perhaps of or a landscape of function. And so also considering other causes than just bruxism as a reasoning for tooth wear. Could be, for example, diets high in citrus fruits or acidy type drinks, carbonated beverages, and in particular, patients that may have gastroesophageal reflux disorder. 22 to 31%, or roughly you could say about a third of people estimate have awake bruxism. And one of the most common reasons for awake bruxism is actually anxiety-related causes. Thanks, Peter. So look, in an academic sense, we like to define things, and we could basically and broadly define bruxism as either primary or secondary. So primary really is saying idiopathic unknown cause, secondary, which is by far more common. And I'm going to touch briefly on both topics or both subtypes, and in particular give you some examples. So idiopathic or primary causes for sleep bruxism is really those episodes in relation to two things. One, it can be relationship to narrow airway. When we talk about sleep bruxism in children, for instance, many of us as dentists will look at our patients and say, how come the deciduous teeth are so excessively worn? You may actually even have parental inquiries about why are their children's teeth wearing so quickly. And the incidence of sleep bruxism in children is estimated to be about 14%. You can see the very data I put here, 3.5 to 40%. Again, one of the reasons for the variation is because a lot of the time when we talk about bruxism in children, it's basically self-reporting or parental reporting. So it's much different to actually a child having a sleep study where we actually have an evidence objective measure as to how much bruxism is actually happening on the night. So useful questions to consider. I think one of them is that when you're looking at a child and particularly looking in the mouth, you could assess things like, what's the significance of the tooth wear? Fair enough, that's one factor. Are they mouth breathing? Can they breathe through their nose? Simply ask them to close their lips and try breathing through their nose. Do they have the dry, cracked lips that we sometimes see? And in particular, the anterior gingivitis, which is classic dehydration related to mouth breathing. We also know, for example, that snoring, particularly or heavy noisy breathing, in younger children is not normal. Some parents will say things like, "Oh yeah, my child snores just like their father." But in reality, that's not normal. In fact, what it is, it's a symptom of a narrow airway, multiple ear infections or enlarged tonsils. Again, remember, as dentists, we get to look at the back of the oral cavity or the oropharynx, and sometimes we can identify quite large palatine tonsils, certainly. Hearing problems in an anxious child, hearing problems because sometimes patients have pain in the temporomandibular joint region, which can be attributed to issues of blocked ear after an ENT surgeon clearly has ruled out ear disease. And anxiety in children or difficulty in sleeping, irritation, hyperactivity of a child, and poor concentration, especially at school, can be behaviours that reflect possible sleep disordered breathing. When we do a sleep study, one of the things we know is that as an adult, if you stop breathing or have labored breathing, that means you actually your airflow is reduced by more than 30% and you have an oxygen desaturation by more than 4% over the episode of sleeping. It's called hypopnea. Apnea is where you stop breathing for more than 10 seconds. We estimate that less than 5 events an hour is actually normal. In a child, 1 or 2 events is significant in regards to brain development. In this article, you can see I put here that children with nasal obstruction had a 65% prevalence of bruxism in their particular study published in 2008. And the Di Francesco study, which I've listed below, showed that there was a significant reduction in the bruxism episodes after tonsillectomy. So we recognise as dentists that just by making some judgment calls, is the child bruxing? Possibly. Does the child have a narrow airway? How would you make that judgment? Is it tonsil related? You might consider referring them off to an ENT surgeon, and you can do that as dentists. We can do that. Obviously, you'll look at the lateral ceph. A lot of us have access to these, especially in the mixed dentition stage when we're planning for orthodontics or future orthodontics. And you can see the circle area here I've highlighted is really reflecting a very large adenoid tonsil. So we do have access to some simple imaging, which can also give us an idea of potential narrowness of the airway. And clearly in this clinical photograph, we can see very large tonsils, palatine tonsils. So I think it's a given that this child has an issue with enlarged tonsils. I think one of the things you can also inquire, are they a slow eater? Because often children, particularly who are the last to finish a meal, are very slow eaters at the dining table. It may be because physiologically, they just physically can't swallow quickly because they've got these large tonsils in their throat. And I think the other thing is sleep bruxism is involuntary. It's actually associated with elements of the sleep cycle, which I'll talk about in a moment. And through the process of what we call sleep arousal activity, you get this movement of the mandible and therefore in some cases contact of the teeth. When you get movement of the mandible, contacting of the teeth, it's called bruxism. If you just get this movement, which is called rhythmic masticatory muscle activity, RMMA, it's a phenomena that occurs very commonly where you get the subtle movement of the mandible without engagement of the teeth. And the thinking is really that that is a technique to help maintain some degree of lubrication of both the throat and the mouth during the course of the sleeping night. Now, this is one of my patients, and he kindly recorded for me his own bruxism, which you can now listen to. And, you know, I think the interesting thing is apart from being the partner next to that patient and having to put up with that, that was not nails on a blackboard. That was actually his teeth contacting. Now, he did not have sleep apnea, by the way, because I sent him off for a sleep study. So for him, his tiredness, his lack of refreshment was due to the arousals caused and the disturbance in the sleep cycle based on the fact that he was bruxing. And we understand too that sleep bruxism in itself, we don't really know why patients do it. We understand that it could be multifactorial. Remember I said earlier, it can be primary, idiopathic, unknown, or secondary to another cause. But we do know that it's not related to what we would say are peripheral factors. In other words, it's not relevant to the occlusion of a patient. It's not because they necessarily are a class 2 div 2 occlusion. 25 years ago, we used to actually attribute malocclusion as a cause for bruxism, but the science has moved on, as has the science behind temporomandibular disorders. And so we know, for example, you can see one study I've just listed here, and there are numerous, where they've looked at correlations between patients who have sleep bruxism and have had occlusal rehabilitation. In other words, idealized occlusions based on the fact that the presence of CO and CR is cohabitable or consistent, versus those patients that did not have occlusal rehabilitation. And there is no difference in the certainly in the etiology of sleep bruxism. So we know that sleep bruxism is centrally driven. In this diagram here, it's really describing the 4 stages of sleep, that is light sleep, 2 stages, deep sleep, 2 stages, and REM, which is what we call the rapid eye movement stage or the dreaming phase. And 80% of bruxism tends to occur in the lighter stages of sleep, stage 1 and 2. So that means within the first, let's imagine, half an hour of sleep, that's where the bruxism tends to occur. And this is called a circadian rhythm, this sleep cycle. So patients go through a process of stage 1, 2, light sleep, 3, 4, deep sleep, REM sleep, back to stage 2, 3, 4, and so on. And each cycle may take about 90 minutes. And we may do 4 or 5, sometimes more cycles per night. And so you can see that in the bruxism instance, 80% will tend to occur more in the lighter stages of sleep. And this is a sleep study we call a polysomnography. And I've highlighted here the fact that you can see the oval areas which represent the actual stopping of breathing, both from the chest and the movement of the abdomen. And also you'll notice the nasal pressure, which is the third one down the bottom there. It's actually also stopped breathing. But once the patient has come out of the apnea event, in other words, blood pressure has risen, heart rate has risen, there's been an indication of brain activity, they've gone from deep sleep to light sleep, reflexes kick in, you get this surge of sympathetic overdrive activity, which you can see on the top part of this slide, which is referring to the EMG on the chin, the submentalis EMG, and we can see the bursts of activity, which is representative of the bruxism. Now, bruxism is actually, in the context of this, as you come out of an apnea event in a patient who has sleep apnea, it's actually a recovery mechanism to help stabilize the airway by increasing muscle tone in relevance to the muscles we call suprahyoid and also the masseter muscles.
Sorry, Michael, I don't know what's happened here.
Might be this one. It's the next one. There's 2 tabs. It's this one.
Sorry, Michael.
That's it.
We can edit that one out. I'm sorry.
No problem. So we understand that again, you go through these cycles. And again, this is sleep bruxism patients who have sleep apnea. Remember, not everybody who has sleep bruxism has sleep apnea. And therefore, it's important to recognize that not every patient you suspect has bruxism necessarily needs to have a sleep study. In previous talks, we've talked about criteria that you can ask your patients. You know, the questionnaires, what's the stop bang? What's the OSA 50? Have you done an Epworth sleepiness score? Have you looked at the anatomy, particularly the position of the tongue at rest? And these are things that you can look at and ask questions to the patients to help give the judgment call, should you send this patient off for a sleep study? And I think one of the important things as dentists is it's not, and it should never be, every patient you suspect has bruxism should have a sleep study. But recognizing that they are important in some cases, I think is very important. Thanks, Peter. So you can see here in the REM stage, we're looking at about 10% of patients can have sleep bruxism. And you get these variety of movements. So, for example, in the muscles of mastication, you can get either tonic contractions or phasic. So tonic would be sustained contractions, or phasic would be where you get action of on-off, on-off, on-off movement. And again, the functionality or the thinking behind the bruxism occurring after a sleep apnea event is thought to be related more to an approach by the physiology anyway to restore airway and therefore breathing. So sleep bruxism has been shown to be linked with several conditions. Morning headaches, jaw pain, temporomandibular joint discomfort, and facial muscle pain. So again, clinically, we might ask a patient, do you wake in the morning and is your jaw stiff or sore? Now, if they say yes, it's reasonable, I think, to say, well, it's likely that this patient may well brux, or and therefore, accordingly, is there a value in consideration of an occlusal splint? Premature loss of teeth and excessive attrition. Again, please bear in mind there are other factors than bruxism that can attribute to tooth structure loss. And disruption to the bed partners. We heard the recording from one of my patients, and I think it's fair to say it can be very noisy and very loud. But remember, clenching is silent. So, sometimes you'll say to a patient, and it's probably not really a practical question, actually, when you say, do you brux or do you grind or clench your teeth? In fairness, a lot of patients don't know. And if it's clenching, the partner may not know either. Understanding that medications, alcohol, amphetamines, caffeine, and smoking, through their impacts on muscle tone and certainly airway irritability, such as smoking, caffeine being a central nervous system stimulant, as is an amphetamine, alcohol impacting on muscle integrity, those things can also contribute to the presence or aggravation, anyway, or frequency of the bruxism. And as I already mentioned earlier, an awareness of the link between obstructive sleep apnea, certainly upper airway resistance syndrome, and bruxism. But see this, there is no causality between sleep bruxism and having automatically obstructive sleep apnea. And I think that's an important observation or take home from this presentation, certainly the first of hopefully several. So secondary causes is much more likely. And we talk about sleep or awake bruxism because obviously awake bruxism is when the person is awake. And one of the things we think about is awake bruxism, one of the most common reasons is anxiety, but there are other reasons too. If you have a patient that suddenly finds they have this uncontrolled habit of clenching, or what they deem as grinding, we would deem as movement of the mandible, consider some relatively uncommon neurological disorders or dystonias. Dystonia really means useless body movement. And one of them is I've recorded from a video from the internet. It's from a neurologist, but it just actually explains in a clinical case what a dystonia can do. And therefore, when it comes to a patient presenting or complaining of bruxism, it may be very relevant.
This individual exhibits an action dystonia, in this case activated by speaking, producing downward pulling at the corners of his mouth bilaterally, affecting his speech quite notably, activation of the platysma muscles bilaterally and anteriorly, which were contributing to slight anterocollis with his head being flexed slightly forward.
So I think the significance of that recording is just simply highlighting that in dentistry, and certainly in our field, we may encounter patients who suddenly may have a condition. I've had 3 in my career so far, called oromandibular dystonia. So dystonia means a useless body movement, and oromandibular because the mandible moves like this and it becomes uncontrolled. The management for these patients is down the pathway of a neurologist. Classic tardive dyskinesia, you can see it looks a rather comical photo, but this gentleman is by no means attempting to be funny. He's actually got an uncontrolled tongue protrusive movement. And usually this occurs through months or years of exposure to what we would say are dopamine receptor antagonists. So some drugs, such as antipsychotic medications, particularly things like risperidone, pimozide, which are prescribed usually by psychiatrists, sometimes by the GPs, as a side effect, it causes this change in the dopamine and levels in response to dopamine. And subsequently, you start to get these uncontrolled movement disorders. Again, management is very much not based on a splint from our perspective, but neurology. And that's it. Yep. And I think one of the more common secondary associations is definitely related to medication use. You know, for example, we know that children who have attention deficit hyperactivity disorder, or ADHD, are treated in many cases using a CNS stimulant called Ritalin or methylphenidate. Methylphenidate is actually not an amphetamine. It's actually a similar chemical to an amphetamine, but the benefit of it seems to stabilize certainly impulsive behavior. And one of the consequences of that is that there seems to be a higher prevalence of sleep bruxism in children with ADHD than there are with those children who are treated with Ritalin versus those that are not, and children that don't have ADHD. We all have a look at our medical histories. We can see, for example, here's an example of a variety of antidepressant medications. And the important point here is that some of these also, as a side effect, can increase the likelihood of sleep bruxism. And I've listed a very detailed, which we're happy to make available to you, a series of more common medications that you might see and references in regards to how and why they actually contribute to bruxism as a side effect. Now, certainly we would not be advocating stopping the medication based on the fact they may be clenching or grinding their teeth. I would advocate that you would say, fine, that's a side effect of the drug. They need to be on the drug because they may have obviously depression or anxiety. What you would do is consider making perhaps a splint to protect the dentition. And you certainly could liaise with the patient's GP. You might have a discussion about considering trialing a different medication. But at the end of the day, the medication's value to that individual and their mental health probably outweighs, dare I say, the impact of bruxism on the dentition. And we also know that there are a number of conditions I've just listed coexist with bruxism. Now, I use the word appropriately, coexist, because it's always easy for us to link cause and effect. So therefore, if you brux, you must therefore have TMD, or if you don't have TMD, you're going to get TMD. There's no evidence to substantiate that. Orofacial pain and headaches can be aggravated by bruxism, certainly. Is it caused by bruxism? Not necessarily in all cases. And is there an association between sleep bruxism and sleep disorder breathing, obstructive sleep apnea, or upper airway resistance syndrome? Well, yes, physiologically, we know that patients that do have these airway disorders certainly can have bruxism as a consequence, certainly when they come out of those events. The point is, does bruxism automatically occur in patients who have these disorders, or does it mean they have them? The answer is not necessarily. And so, you know, Shetty et al. Published a very interesting article looking at bruxism. And generally speaking, in broad terms, if you divide it up as sleep bruxism or awake bruxism, usually a sleep bruxism patient will talk about pain in the stiffness of their jaw, or pain in the jaws on awakening improves during the day, whereas awake bruxism will generally say they wake up feeling quite good, and then as the day progresses, their facial pain or jaw pain increases. Again, it's just using the history as a guide to indicate, is there a tooth clenching or tooth grinding issue that they may have? And, you know, clinically, we can look at suggestions that they have bruxism. You can see here in both these photographs, scalloping of the tongue margins of the lateral border of tongue. Often you do typically see that in a patient who has bruxism. It's actually the thrusting of the tongue against the lower natural teeth. You can see here on the cheeks, we've got the linea alba. It's quite prominent. If you have a look at the lateral border of the tongue there, you'll see a collection of these scalloped areas, but you also see whitening or thickening of the surface of the tongue. This is hyperkeratosis. It's a mechanical response to mechanical trauma, and the tissue has thickened to protect itself. So again, if you had a patient, let's imagine, who had quite prominent linea alba, had the scalloping of the tongue, quite prominent white plaques along the lateral border of the tongue, one of the things you could entertain is hyperkeratosis, perhaps secondary to bruxism. Hypertrophy of the masseter muscles, again, may be a representation that this patient has a bruxism issue. Certainly, you can see in these photographs, both these gentlemen have quite large and very broad masseter muscles. And trismus, not every patient who has trismus has bruxism issues, but again, limitation or restriction in mouth opening may be a consequence of TMD. Therefore, there's muscle pain or joint pain, or maybe mechanical changes in the joints. But as you work your patient up with the TMD assessment, one of the things you may consider also, is there a sleep bruxism or awake bruxism issue? And burning tongue, I mean, that's a comical photo, I know, but if you get a patient who actually has symptoms of burning associated with the lateral border of tongue or the tip of the tongue, I would encourage you to think about mechanical trauma, and one of them can be the bruxism. And there's a lot of interesting dogma, which I'd like to talk about as well. And I just want to share with you some systematic meta-analysis data and findings, just to help explain the associations that we've always held about bruxism in certain conditions. Firstly, we know that bruxism can certainly loosen teeth, but we also appreciate that there's no association, or there's no evidence to validate, statistically anyway, that traumatic occlusal forces leads to periodontal attachment loss or gingival recession. And that was published, as you can see here. I've highlighted World Workshops on Classification of Periodontal and Peri-Implant Diseases and Conditions 2017. And it's also no linear relationship between bruxism and clinical signs and symptoms of periodontitis. So you might remember the Linda publications, particularly they were published in the early 80s, and they looked at beagle dogs, and there was an association between correlation of occlusal trauma and loss of periodontal attachment. That was in beagle dogs. In humans, it does not seem to be this relationship. Secondly, have a look at the next slide. You'll see an image of a patient's teeth. And of course, we're all directed our eyes to the lower incisors, the tooth wear. We can identify some chipping in the incisal edges of the maxillary incisors. And the next slide. But again, there's no relationship, interestingly, between the severity of tooth wear and sleep bruxism. So what does that really mean? Well, what it really means, in my view, is that when you look at someone's teeth, particularly if they have evidence of incisal chipping or evidence of significant wear, you do consider other factors. Yes, sleep bruxism may be a problem or contributor, but the other thing is you're looking at a landscape, perhaps of a lifetime of functioning. And it doesn't necessarily mean because you see the patient with the tooth wear that the necessarily bruxism is occurring at that time. And it may be that they've had episodes of this in the past. And so again, it doesn't always mean they automatically have to have an occlusal splint, because on the off chance that they might still be bruxing. Tooth wear in young adults is considered to have a modest diagnostic value. So again, you might look at the age of the child or the teenager, and clearly if you had a patient, let's say, who was a teenager and they had quite flattened cusps on their 6s and 7s, it could be argued that's actually quite a significant indicator. And again, you'd look at other factors such as bruxism, sure, but you might also consider other factors like diet, especially carbonated beverages, citrusy fruits, that type of thing, and if there is any reflux, as we all know as dentists. And secondly, the question about, does bruxism increase the likelihood of failure of implants? Again, Manfredini published in 2014 a meta-analysis, systematic meta-analysis, looking at the review of the literature on implant failures and the association with bruxism. And you can see in this slide here, they looked at, in the end, 14 papers out of over 1,000 they reviewed, because one of the things they look at is obviously the design of the studies, if there's any bias in the design of the study, for example, sample size, selection of patient criteria, the definition of how they define bruxism. And in these 14 papers, there were over 1,000 papers. This is quite a reasonable number of participants involved with 3,447 implants, and they followed them up over a variety of periods of time from 0 to 15 years. And the criteria was, with regards to bruxism, was it self-reported in 13 of the 14, which it was. And again, remember what I said earlier, it's not always a reliable indicator. And 1 in 14 actually had a PSG study which validated bruxism. And the conclusions were that the biological failure of an implant, no, in 6 papers that bruxism was not relevant. There were 8 papers that were uncertain. So the question about bruxism and failure of implants, it's not ruled out, but it seems to be an unlikely precipitant. But mechanical failures of restorations, it is reasonable, and they certainly concluded that in their publication, that it was reasonable to assume bruxism can cause failure of restorations. Again, just looking at their data, they had in this particular summary over 700 patients. They had 2,590 implant patients, which obviously had restorations associated with them, follow-up over 4 years. And they found that mechanical failures, such as screw loosening, screw fracturing, implant fractures, and ceramic fractures, the conclusions were yes in 4 papers, no in 2 papers, and uncertain in 1. So they actually only, in the end, had 7 papers that they actually considered valid. And as dentists, we all know what fractured teeth look like. As you can see here, have a look at the bottom right-hand side there with the wearing of the porcelain on the bridge work. And again, what's the clinical consequences of bruxism in relation to TMD? Does every patient with TMD automatically have a bruxism issue? Again, the answer is no. And in this particular publication in 2010, again, they looked at a systematic meta-analysis. Now, these are very meaningful. Using the Cochrane analysis is a very meaningful way of reviewing the literature, because it actually tends to eliminate studies that perhaps might be informative, but perhaps poorly designed. There may be biases in the design of the studies, and therefore the conclusions that we make. And remember, as clinicians, we base our decision-making on the evidence base that we have in front of us and what we have available for us to read. And so in this particular 10-year review, they looked at 46 published articles that they deemed reasonable. Self-reported questionnaire, again, 21 out of the 46 had self-reported bruxism. And you can see yourself, 7 had clinical assessments, only 4 had sleep study based, and only 2 had an EMG related based diagnosis of bruxism. And again, the association of bruxism based on self-reports and clinical assessment, that means worn or chipped teeth, there was much higher reports associated with TMD than those that actually had objective studies to validate sleep bruxism. So again, when we ask our patients, are you aware you tooth grind or clench? In fairness, they may not know, but if they do say yes, it could be a very relevant contributor to the presentation and therefore the management of TMD, but it may not necessarily be a relevant factor, and it may not even be relevant in the patient who's got TMD altogether. So the conclusions of this really is there's no direct relationship with signs of bruxism and symptoms. So you can't look at someone's mouth and make judgment calls that they're actively bruxing, because my question to you is, how do you know? If you've got the benefit of digital scanning, and we know that sometimes colleagues can do that, they digitally scan the dental arches, and then over a 6-month period, they repeat it. And then over a period of time, they can actually quite accurately determine if there's tooth structure loss. That's actually quite objective. But just looking in someone's mouth, you can't make the judgment call. And secondly, awake bruxism is very hard to measure. The reason being is because, patients often may tend to self-report clenching or grinding of their teeth, but they may not. They may be focusing on other things, and that's when these activities are happening. And sleep bruxism doesn't occur every night. That's what makes it really hard to study. You might recall Linda saying earlier, not every sleep study confirms bruxism. That's because on the night they had the study, there may not have been episodes of sleep bruxism. Other nights, there could be quite profound sleep bruxism. So a patient can actually sleep brux nightly, weekly, once a month or more. It depends very much on the individual. So I suppose really from that, what's the next step? And I think as dentists, one of the things we would do is we'd say, well, what can we do that's conservative, that's relatively evidence-based to help our patients? And obviously consideration of an occlusal splint is not an unreasonable consideration. And obviously complete arch coverage, in my view, is much more preferable, and certainly the literature backs me up on this, than a partial splint, in other words, partial coverage of teeth. Hard acrylic is preferable to soft rubbery ones. Equally, bilateral contacting is very important. So in other words, we can't biologically stop bruxism by making a patient a splint, but what we can do is protect the dentition, and in many cases try to reduce perhaps how hard the bruxisms were going, how much muscle activity is happening, which often is one of the reasons why patients report awakening in the morning with a less stiff or painful jaw once they've got the splint. Michigan splints, flat plane splints are the main, I suppose, considerations for dentists for their patient. And I certainly tend to use a flat plane splint. Thanks, Peter. And we know that, intermittent use for a patient wearing a splint rather than every night for the rest of their life is preferable. It's interesting that because most patients who have TMD, we'd certainly advocate for about 90% of patients, in fact, we'd say, look, 6 to 12 months, they'd probably be wearing the splint every night, and then gradually we wean them off it, and then they would use it when they need it. I think what was interesting too was the finding, certainly in this article, that 3 millimeter interocclusal distance was superior to 6 millimeter in their particular findings. I have to say, as an empirical data, in other words, an empirical comment, often patients who come to me with an occlusal splint, where they might say they still wake with discomfort in the jaw, stiffness or pain, we actually, and I do, automatically increase the interocclusal distance by 3 or 6 millimeters. So yes, that's quite a dramatic change from what I'm just saying to you, what the conclusions were in this particular article by Manfredini. And the restrictions of movement, in other words, making a splint that restricts movement of the mandible is not necessarily a clever idea, because what will happen is as the patient attempts to brux, you get much greater workout in the mechanism of the jaw, and you often find you get exacerbation of any TMD symptoms. Again, flat plane, we all know. I use the milled devices. I use the ones from the dental solution. I have done for many years. I actually like them because they're not bulky. They are actually, because they're milled, as you know, you do your scanning, or you may choose to do alginate impressions or rubber-based impressions of the teeth. My advice is do an occlusal or bite registration in centric occlusion as well. The reason being much less adjustment when the device is fitted. Some colleagues like other types. The Gelb splint is something I actually don't use, but the integrity or the design of it is such that it fits over the lower arch so that you only have posterior teeth engaging and no contact on the anteriors. Again, you might ask, well, is the possibility of tooth eruption there in the anterior segment? It's possible. And so it's one of those ones I personally don't use, but again, some colleagues really like that. And I think the advantages of an occlusal splint, and again, this is based on a 10-year review that was published, is several things. The first one is it does protect the teeth. The second one, it has an influence in patient behavior. Now, you might ask, how does that work? Well, one of the hypotheses is that patients who actually wear a splint at night, they say that they tend to have this sense of minimization of tooth contacting during the day. Now, again, you can see this is a rather old study, 2002, but it's an interesting concept. And again, patients having the opportunity to take control of their disorder, their control of their symptoms by having the tools in the toolbox, such as a splint to use when they need to, is actually quite a good idea in my view. Of course, there are limitations too. Some patients will complain that they actually grind or clench more since they've got the device in the mouth. In those cases, what I would say to the patient is, yes, but you've got a foreign object and intuitively you're more aware of the fact that you are doing those behaviors. Remembering, splints does not stop bruxism. And again, if you've got partial coverage of the dental arches with the splint, you may actually find you get tooth movement. Again, not common, but it can happen. And anterior repositioning splints, which are designed in principle to try to re-engage the condyle onto the disc if the disc is displaced. Again, every colleague likes to do or use what they like to use. I don't use them. But again, some patients prefer to use them, or colleagues do anyway. And I think the last thing is don't recommend, and a patient shouldn't be wearing a splint 24/7. There are different schools of thought in how we treat patients with TMD. There is a school of thought which does use an anterior repositioner in an attempt to try to supposedly reassociate the condyle with the anteriorly displaced disc. And then they have a device they wear during the day and one they wear at night. It's an interesting school of thought. I'd question the evidence base behind it, because one of the dangers you have is that a patient then becomes very dependent on having a splint in their mouth during the day, and if they take it out, they get pain. And some patients I've met where they've actually been encouraged to actually have to eat with the splint. Again, the idea of using splints, they're aids to recovering. They're not really intended to become another problem or make what I would call a dental cripple. Treatment of wearing a splint then really, in my view, should be worn at night. It's important to, obviously, as part of your normal routine, to adjust the splints. So if you see a patient every 6 or 12 months, get them to bring their splint along. Don't just look at it and say, oh yeah, I can see you've been active tonight or that time over that time frame. Use some articulating paper. Check to see if it needs adjustment. Use your acrylic burr and polish them. If they're smooth, they work much better than if they're rough and ragged, particularly those patients that have those classic gouges where they've been horizontally grinding their splint over an extended period of time. Eventually, a patient can be advised they can wean them off the splint. As I said earlier, about 9 out of 10 people we can after 6 to 12 months. But certainly those patients, about 1 in 10, like to wear their splint because they feel more comfortable wearing it. They actually feel better in the morning when they wake. There's no reason why they can't wear them every night for long term. Again, it's just a matter of making sure when you review the splints that they're even, and you've actually checked to make sure that they are even, and more importantly, polished or smooth. And this is a rubbery one. Look, again, I'm not critiquing people that make soft splints, but you might consider, and I would suggest you do consider, a harder splint first. Sometimes you'll find the rubbery splints act like chewing gum, where the patient tends to spring off them all the time. And secondly, patients can obviously destroy them quite quickly. And as I said earlier, consideration of that 90% of your patients will wear the splint periodically when they need to, which is quite a reasonable approach. And we understand that with bruxism, there certainly are other modalities. I mean, surgery doesn't have a role to play in bruxism. The role of Botox is a consideration in some people. Botox, as you know, would be targeting temporalis and masseter muscles. The use of Botox, it usually lasts about 3 months. They'll have then a repeat treatment. I have had patients referred to me where they've actually had Botox for several therapies before they've been referred, and no discussion of a splint, no discussion of physiotherapy, certainly if they've got TMD. And again, I'd ask you, consider some more conservative options perhaps before automatically considering Botox. And medications, pharmacotherapy. There are some medications that have been shown to be of some benefit in reducing sleep bruxism. But again, if you think about it, if someone's got an issue with bruxism, medication has a role to play in pain management, but I think using it as a long-term treatment for bruxism would be very highly questionable. BruxApp is something novel that I put up here. It's a new type. It was actually designed for a study on awake bruxism. The patient downloads the app called the BruxApp, and you can see the different colors on the screen of the phone, and each color denotes different terminology. For example, are your teeth contacting? Were they just lightly clenching? Were you grinding? Or was the jaw clenching without teeth contact? So you might say, what's that? In other words, muscle tension. These type of things sometimes bleep up. The patient would then just push the relevant section, and then you get some degree of objective measure over a period of weeks or months as to how often the patient did actively move their mandible, whether they clenched their teeth, they were aware they grinding their teeth, whether they were aware that they weren't touching their teeth, but their muscles tension was increased. It's more a research tool than a real clinical tool. But again, if you've got a patient that thinks, well, how can I help myself? in preventing daytime tooth bruxism, you might consider perhaps as a novelty one of these apps. And the pharmacology approach, as I already touched on, was Botox. Clonazepam is a drug we do use for movement disorders. So, you know, the case I presented of the gentleman with the dystonia, where he had the movement of the mandible and the contraction of what we call the platysma muscles, or patients that have oromandibular dystonia, patients who have acute TMD, where they have absolute muscle pain, absolute jaw pain, can't open their mouth. Clonazepam can be very useful for short-term use, but again, it does reduce sleep bruxism based on studies, but I would not be recommending or endorsing using benzodiazepines as a treatment for sleep bruxism. Clonidine is a drug that's also been shown to reduce sleep bruxism, but it does drop blood pressure. And again, it's really out of the domain of us as dentists to prescribe those drugs. And again, you'd have to question the value of prescribing when you can make a patient perhaps a splint or look at more conservative options. As I said earlier, Botox is certainly something that is considered a treatment. In my world, it's one of the last things I consider. I certainly don't consider it in my first 5 or 6 suggestions to a patient. And it doesn't stop bruxism, it only reduces the power or efficacy of the bruxism. So again, you could argue the role of a splint perhaps as a consideration first is quite reasonable. And we also know again that the effectiveness of bruxism, although is certainly a treatment modality, it's certainly something that is used in the treatment of patients who have chronic facial pain, TMD, certainly headaches, and bruxism, and its management in bruxism, the jury's still out. In other words, is the evidence base enough to say that every patient should have Botox? The answer is no. So on the finality here, I just thought I'd like to invite you all that are watching this webinar, those of you that are lucky or unlucky to live in Melbourne, don't know, but certainly in Ballarat, they have freedom. We're involved in hosting a day course on dental sleep medicine. We've got a number of specialist colleagues presenting in the day, looking at things like sleep medicine being presented by Dr. Linda Schechter, the dental management of a patient, including how did you do a George gauge, how would you work out if a patient's suitable for a mandibular advancement splint, what would you do with a patient who's got bruxism, how would you treat a patient who's got temporomandibular disorders by myself. We've got Mr. George Dimitrioulis, MaxFax surgeon in Melbourne, presenting MaxFax solutions for sleep apnea and certainly talking about temporomandibular joint surgery, and so is less than 5% of cases. We have Dr. Frank Kale, who's an eminent sleep psychologist, would be coming and talking to you a little bit about insomnia and some of the ways and means that even as us as colleagues, we can help our patients. And Mr. Peter Field, who is no doubt an expert in the business of dental sleep medicine, has been involved in the area for many, many years. We'll also be talking about ways and means of incorporating the concept of dental sleep medicine in your practice. So hopefully we get the pleasure of meeting you in person. Thank you very much.
Michael, thank you. That was brilliant. I'll just stop sharing now. There we are. We're back. Michael, I just thought I'd throw it open for questions. I had one question, and I guess that was obviously our lives, particularly in the last couple of years, have been fairly stressful. Are we seeing an increased incidence of bruxism in patients presenting to you?
Well, it's a good question because, look, we know that certainly a lot of patients I've treated who have had TMD, and we've had pretty good results with their management, they've had relapses. So we know that anxiety can certainly increase the prevalence of clenching, certainly during the daytime, or bruxism during the day generally. And so it's fair to say that the answer to that question would be yes, it'd certainly be a factor. And I have seen it. As I said, I've had patients that have been very successfully managed over a number of years, no pain, doing very well. They're wearing a splint at night. Sometimes they haven't had to wear the splint. And with regards to our experience, certainly in Victoria, a lot of those patients, I have to say, they have had relapses.
Okay. Michael, thank you for that. That's the only question I have. Linda, did you have any questions of Michael?
Of course I do. Sorry, Michael. Just very quickly, I've got a few questions actually. In the patient that bruxes who's got snoring, I suppose, when do you actually just do an occlusal splint, and when do you look at doing a mandibular advancement splint in the patient that doesn't have a lot of sleep apnea symptoms?
I think one of the things is with the snoring, I think it's fair to say to you that if you make an occlusal splint, you're likely to aggravate the snoring because you're actually compromising tongue space. So if I had a patient that said to me, look, I'm really a bad snorer as part of my assessment, I probably would encourage, even if one had a simple level 4 perhaps or level 3 sleep study, just to get an idea if there is an airway issue before you make an occlusal splint. And I have patients who don't snore that suddenly start to snore once they've had the occlusal splint, because again, it's about volume and tongue space. And so one of the techniques I do, if you get a patient, you make an occlusal splint and they start to complain of snoring, you also must make sure you've got lots of room palatally. So we can adjust the devices to maximize space for the tongue to try to reduce the likelihood of the snoring. But if someone does acknowledge that they snore, even if they didn't want to go for a proper level 2 or level 1 sleep study, even considering some of the more simpler ones, just to get an idea if there's apnea, is actually quite useful.
Thank you, Michael. I just want to ask about, if you've got a patient who does have mild sleep apnea who also bruxes, is there any particular type of splint that would be better for them to protect the teeth as well? So do you find a particular splint is a better way to go?
I think the most important thing about that would definitely be, number one, obviously they have to have the 2 parts to the device. So you have to have an upper and a lower dental arch device. So you've got and allow for freedom of movement. So any device that you consider for sleep apnea management that doesn't allow movement of the mandible and therefore bruxism will increase the likelihood of that patient getting TMD symptoms. So the benefit of an MAD is really that you can protect the dentition and you can also maintain a patent airway. And so you can literally kill 2 birds there with 1 stone. But the most important thing is the device has to be made so that you can have the lateral movements of the mandible.
And just thank you for that. And just one more question. For follow-up of these patients, obviously as things change over time and people put on weight and all those sort of changes, at what sort of frequency would you be following them up? So
with an occlusal splint?
With just an occlusal splint, yes.
Look, what I advocate is if I'm treating them for TMD, usually I'll see them probably 3 or 4 monthly initially until we get resolution of the symptoms. And if a patient is continuing to wear the device every night, I always recommend that when they go to the dentist, they bring their splint along and get it checked as part of their normal routine examination. So that could be 6 or 12 monthly. Because one of the things about it is I've had patients say to me that I say, oh, does your dentist ever adjust your splint? And they go, well, they look at it. And I think looking at a splint's good, but actually making sure you use articulating paper, and if you need to adjust to make sure it's balanced. And if you have a lathe, you can polish them even better, because they work much better if they're smooth. So I think as a routine, if you make a patient an occlusal splint, you should make it part of the routine that they bring it along if they're having a restoration, which I appreciate for colleagues is obvious, but also as part of their normal routine examinations, 6 or 12 monthly.
Thank you.
You're welcome.
Thank you, Michael. Thank you, Linda. We don't have any more questions tonight, so I just wanted to say thanks to you 2 guys again for your time tonight. Look forward to seeing you on the 31st of July in beautiful downtown Ballarat.
Yes, we look forward to seeing everybody as well.
Okay.
Thank you.
Thanks, Michael.
Thanks.